with our first session. It was intended as the second session. Dr. Beela Mathew, MD DNB, Professor of Radiation Oncology, RCC Trivandrum. I request Madam to please deliver your session. Madam will be talking to us about ER/PR+, breast cancer, stand-apart, personalized treatment from the heart.
Good afternoon, everybody. The outside Leonard and Professor Mathew and his team for inviting me for this talk. I have 15 minutes to compress what has occurred over nearly 130 years. As we all know, endocrine therapy is the oldest systemic treatment for breast cancer. The hypothesis or the concept of endocrine therapy was proposed in 1889 when Professor Schitziger observed that older men have a better prognosis. The first case report on endocrine therapy was published in 1896. It makes for actually very interesting reading. If you want to look at it, it's available in PubMed. In 2024, we have come through an armamentarium of agents including estrogen receptor modulators, aromatase inhibitors, ER downgraders. We've gone back to ovarian ablation or suppression again, and other targeted agents. We know now that 70 to 75% of breast cancers are HR positive, so endocrine therapy is a very important part of the treatment of breast cancer. The outcome with endocrine treatment is proportional to the strength of ER and PR expression. More than 10% of HR positivity is an indication of endocrine therapy, which is more than or equal to the score 4 of ALRED, which is the government scoring system that is employed. And the choice of therapy depends on the menopause and disease status. So how do we define menopause? Menopause is defined as clearly if somebody has had bilateral oophorectomy or aged more than 60 years. In age less than 60 years, if they are amenorrheic for more than 12 months, in the absence of chemotherapy, tamoxifen or ovarian suppression, they have to have an estradiol or FSH in the postmenopausal age. For those who have received chemotherapy, you have to do serial monitoring of FSH and estradiol before you decide that they are truly menopausal. So, we started off with ovarian ablation. There were several patients who were treated with ovarian ablation. And in the 70s, we come across our good old tamoxifen, which was considered as a wonder drug. We know that tamoxifen confers a 30 to 50% objective response rate in metastatic breast cancer. The EBCTCG meta-analysis published in 2011 showed that 5 years of tamoxifen decreases recurrence by 13% and death by 9%. And the benefit is irrespective of age, menopausal status, nodal status, stage and use of chemotherapy. Further on, there were trials addressing whether 10 years of tamoxifen is required. And 10 years of tamoxifen was shown to confer a 25% decrease in risk of death at 10 years, but the absolute benefit was 2.8% only at 15 years. And there was also an increased risk of endometrial cancer, 2.2 times in those who received 10 years of tamoxifen versus 5 years, with a related death occurrence of 0.2 to 0.5%. Next came the newer generation aromatase inhibitors, letrozole, anastrozole, and exemestane. They were shown to have improved overall survival, clinical benefit, and time to tumor progression in metastatic disease. In the adjuvant setting, they have been used in 3 settings: upfront, sequential, and extreme adjuvant. Trials showed that though they improved disease-free survival, there was no difference in overall survival. And so, decision regarding aromatase inhibitors is taken based on risk and potential benefits, patient and tumor characteristics, comorbidities, bone mineral density, and full circle to the role of adjuvant ovarian suppression. This was addressed in SWOT and textiles. In the combined analysis included more than 4,000 patients of tamoxifen into 5 years versus tamoxifen plus ovarian suppression or exemestane plus ovarian suppression. At a median follow-up of 13 years, it was shown that both tamoxifen and OFS conferred a 12-year improvement in DFS and overall survival. Exemestane and overall survival versus TAM and overall survival showed DFS benefit but no overall survival benefit. The overall survival benefit was more significant in high-risk patients, age less than 35 years, tumor size more than 2 centimeters, node positive, grade 3 tumors, HER2 positive or post-NACT. So, how do we treat premenopausal adjuvant endocrine therapy? Low-risk patients, those who have all of the following: tumor size less than 2 cm, grade 1 or 2, node negative, Chi67 less than 20%, may be treated with tamoxifen for 5 years alone. For high-risk patients, if they have more than 2 cm T, grade 3, node positive patients, Chi67 more than 20%, you go for either TAM plus OFS or AI plus OFS for 5 years. TAM for 5 years is an option if OFS is not feasible. And then you consider them for extended adjuvant treatment, either tamoxifen or AI, depending on the menopausal status at that time. For postmenopausal women, again, low-risk patients could be offered AI for 5 years, or 2 to 3 years of TAM followed by AI, or TAM for 5 years. For high-risk patients, you consider extended adjuvant to 10 years or at least 7 to 8 years, of which at least 5 years are AI. What about the new targeted agents, adjuvant CDK4/6? The Monarchy study showed benefit for abemaciclib in addition to endocrine therapy. At 5 years, there was a 7.6 absolute increase in invasive disease-free survival, no difference in overall survival. The NATALY study tested ribociclib 400 mg per day for 3 years. This was associated with a 3.3% absolute increase in invasive DFS at 3 years. There is no overall survival data published yet. But palbociclib, another CDK4/6 inhibitor, as we know, should not show any benefit in the adjuvant setting. I leave you with this paper from Haslam et al., which is published recently in the European Journal of Cancer, where they have contested that the results obtained by Monarchy and NATALY are probably not going to stand out, and they've pointed out some flaws for the trial design, the trial design, what happened during the study, like the excessive dropout or loss to follow which occurred early, the significant adverse events and financial toxicity that this has brought about, and they are not advising routine use of CDK4/6 inhibitors, and advises that we should await for more mature data. Adjuvant PARP inhibitors, the Olympia trial, was a phase 3 placebo-controlled study in BRCA positive patients where adjuvant olaparib for 1 year conferred 7.3, 7.4 and 3.4% absolute benefit for invasive disease-free survival, distant disease-free survival, overall survival in 4 years. Bone modifying agents, we have the EBCTCG meta-analysis published in 2015, where bisphosphonates were found to have a significant benefit for recurrence, distant recurrence, bone recurrence and breast cancer mortality in postmenopausal women. There were no difference between the agents, clotonate, ibandronate or zoldronic acid. And adjuvant denosumab is also an alternative which has shown improved disease-free survival and bone metastasis-free survival in HR-positive patients. A word about neoadjuvant endocrine therapy. We generally do not consider neoadjuvant endocrine therapy except for elderly women with comorbidities where we do not consider them from chemotherapy. Retrospective data has shown that neoadjuvant endocrine therapy does cause downstaging in 40% of patients. The PCR rates are only 1.3%, but still there is a PCR rate. There is a phase 2 study in 500 patients which also showed a PCR rate of 1%. 50% conversion to BCS. So in an elderly patient who cannot tolerate chemotherapy, neoadjuvant endometriosis is a reasonable option. You have to remember that the duration of neoadjuvant therapy should be between 4 to 6 months before you take them up for surgery. Metastatic disease. We know now that endocrine therapy is the mainstay of systemic treatment for HR-positive HER2-negative cancers. The average tumor control in first line is 8 to 12 months, and second line is 4 to 6 months. And the indication for starting chemotherapy is extensive visceral mets or visceral crisis de novo, symptomatic tumor progression or resistance to multiple endocrine therapies. Apart from tamoxifen and the aromatase inhibitors, fulvestrant, everolimus, CDK4/6 inhibitors, another SERD and AKT inhibitors have all come into play now for treatment of metastatic breast cancer. Fulvestrant is an agent which is an ER downgrader, which is 100 times better ER binding, versus tamoxifen. It causes rapid degradation of the fulvestrant ER complex, so that it is no longer available for estrogen. It has been shown to be non-inferior to tamoxifen, of equal efficacy to anastrozole. Progression-free survival is significantly longer with the higher dose of 500 mg. Superior overall survival versus anastrozole in first line. So fulvestrant is recommended in the first line or second line setting. Again, CD4/6 inhibitors. This table shows the first 3 columns are women in postmenopausal age group treated with palbociclib, ribociclib or abemaciclib along with letrozole. There is a significant median progression-free survival, whereas the overall survival benefit is available only with ribociclib. So also the MONALEESA 7 was a trial in premenopausal or perimenopausal women with ribociclib, letrozole, anastrozole or tamoxifen along with LHRH agonist. This also showed a significant difference in median progression-free survival and median overall survival. mTOR inhibitor, everolimus, is an agent that has been tested in second line with exemestane, tamoxifen or fulvestrant. Again, they showed median progression-free survival or time to tumor progression, but no difference in overall survival. SOLAR-1 is a study which tested alpelisib, which is PIK3 inhibitor, along with fulvestrant versus fulvestrant alone. The study showed a median progression-free survival benefit for PIK3 mutant tumors, but no difference in overall survival and no difference in non-PIK3 mutant tumors. Elacestrant is a new SERD which has been developed. It's an ER alpha antagonist, oral non-steroidal SERD. It is active in ESR mutant tumors. The overall trial was an open-label phase 3 study in postmenopausal women, where elacestrant was compared with standard of care endocrine therapy, AI or fulvestrant in second or third line post CDK4/6 inhibitors. There was a progression-free survival benefit of 3.8 versus 1.9 months with a significant p-value, but you have to notice that the absolute benefit is 1.9 months. And at the cost of grade 3 or 4 side effects of 7.2% versus 3.1%. This is the newest kid on the block, AKT inhibitor capivasertib. Again, this is awaiting FDA approval. Phase 3 randomized double-blind trial showing a median progression-free survival of 7.2 versus 3.6 months, which is considered, which was significant p-value. Median PFS was 7.3 versus 3.1 in AKT altered tumors, which was also significant, but there was a discontinuation due to adverse event of 13% in the intervention arm versus the standard arm. So, this is metastatic breast cancer management guidelines. For first line is an AI or fulvestrant with CDK4/6. And if no mutation is detected, second line goes for everolimus exemestane or everolimus with fulvestrant if it hasn't been used earlier, or switch endocrine therapy with CDK4/6 or fulvestrant monotherapy. For PIK3 mutated tumors, fulvestrant with alpelisib is an option. For ESR mutated ones, elacestrant is a newly FDA approved agent. And for BRCA mutated patients, we have PARP inhibitors. I would like to conclude with this article. This was a recent publication in the JAMA. Clinical benefit and regulatory outcomes of cancer drugs receiving accelerated approval. They published that 129 cancer drug indication pairs were granted accelerated approval between 10-year period of 2013 to 2023. Now, if you know, drug accelerated approval means they are approved based on early results or surrogate markers in most studies. And they are supposed to be followed up for more tangible or meaningful endpoints like overall survival or quality of life, which makes a lot of difference to the patient. So this publication, they found that only less than half showed benefit in confirmatory trials. 48 drug indication pairs converted to regular approval, of which 40% proved overall survival benefit, 44 showed only PFS benefit, 10% showed only response rate with duration of response, 4% response rate, and even one drug was approved even though it was a negative confirmatory trial. The authors conclude that most cancer drugs granted accelerated approval did not demonstrate benefit in overall survival or quality of life within 5 years. Patients should be clearly informed about the cancer drugs that use the accelerated approval pathway and do not end up showing benefit in patient-centered clinical outcomes. Thank you.
Thank you, Beela. I think first answer session